In this next scenario, it's called a Megacode, and it combines the knowledge of procedures and treatments from multiple ACLS algorithms. In our scenario, you'll be the ACLS team leader with a 45-year-old male patient who appears to be unresponsive. A witness states that the person had a choking emergency where an object was removed. The patient was brought to advanced medical care because he was having a difficult time breathing after the obstruction was removed. Now, as you begin to talk to the patient, he stops responding to all questions. Remember to use your basic life support before moving to advanced life support. The patient should be checked for responsiveness. If unresponsive, a code should be called. Then check for a pulse and for breathing. In our scenario, the patient is in respiratory arrest. A basic airway like an OPA or an NPA should be inserted. Then, we're going to start rescue breathing with a bag valve mask at 15 liters of oxygen. We're going to deliver 1 breath every 5 seconds. Remember, vitals should be taken and an ECG monitor should be attached. The rhythm on the ECG is a normal sinus rhythm with PVCs, or preventricular contractions, at 78 beats per minute, but it's irregular. Knowing that a rhythm with multiple and frequent PVCs could deteriorate quickly, we're going to start an IV in order to administer IV saline and have a route for medications. After some time of rescue breathing, the monitor appears to show a pulseless rhythm. It looks like ventricular fibrillation. We check for a pulse physically to find that the patient has no pulse. So, it's now time to start CPR with cycles of 30 compressions to 2 rescue breaths. The defib pads are applied while CPR is in progress. When the pads are in place, the leader will tell everyone to stand clear while the rhythm is analyzed. VFib is still present on the ECG. With a monophasic defibrillator, we're going to go ahead and charge to 360 joules to shock our patient, and CPR is then continued. Since we have VFib, the first shock has been given, and an IV is established. It's now time to go with our first medication. Epinephrine at 1 milligram of 1 to 10,000 while CPR is still in progress. The CPR helps to circulate the medication throughout the body and especially get it to the heart. Remember that CPR is not stopped when drugs are administered. Now, after 2 minutes of CPR, it's important that the compressor switches with the defibrillator. This helps to make sure that we have a fresh compressor who will be able to give us consistent compressions at a rate between 100 to 120 compressions per minute at the appropriate depth. Before resuming CPR, a look at the monitor reveals persistent VFib. Another shock with a monophasic defibrillator is given at 360 joules. This time when the monitor is checked, a sinus rhythm is evident. A pulse should be checked to make sure that we have a perfusing rhythm. In our scenario, the patient has a pulse, but he's still not breathing. Breath should continue at 1 breath every 5 seconds. The leader needs to call for a set of vitals to determine the next treatment. We find a blood pressure of 88 by systolic when we have achieved ROSC, or ROSC, which means return of spontaneous circulation. After a cardiac arrest, a systolic blood pressure below 90 really requires a liter or 2 bolus of normal saline to get the blood pressure up. Since our patient is still in respiratory arrest, we need to get an endotracheal tube in place and monitor capnography. With capnography, we can verify tube placement when we have a persistent capnographic waveform. Capnography measures the concentration of carbon dioxide in exhaled air at the end of the expiration. The CO2 that is detected by capnography is produced in the body and delivered to the lungs by circulating blood. A sudden increase of detectable CO2 may be an indication that ROSC is likely, and effective gas exchange at the cell level is occurring. The normal range after ROSC is between 35 to 45 millimeters of mercury. Persistent low values less than 10 millimeters of mercury during CPR could be an indication that ROSC may be unlikely. Our Megacode scenario will end with getting a 12-lead EKG, another set of vitals, and considering why this patient went into cardiac arrest, so that this patient's life can be saved by correcting those underlying problems.